Chapter 23, Respiratory Anatomy, Screencast 4. This screencast will be focusing on a number of various structures. We'll be starting off with the respiratory zone, then we'll actually be moving on to the lung, gross anatomy of the lung, and then on to the pleura. Now, we're going to focus first on the respiratory zone, and the respiratory zone is made up of the respiratory bronchioles, alveolar ducts, and the alveoli themselves. When we talk about the alveoli, each lung contains anywhere from 300 to 400 million. Another structure associated with the alveoli are alveolar pores. These are openings that we're going to find that actually allow for collateral ventilation. The alveoli are also going to be very well vascularized and surrounded by pulmonary capillaries. There's going to be an intraalveolar septum, and this is where we find the elastic fibers that we have addressed previously. Now, there are two general types of alveolar cells that make up the alveolar wall. Type 1 cells, they're the most common of the two cell types, and they making up the alveolar wall, and they account for 95% of the alveolar surface area. They actually will form the alveolar epithelium of the respiratory membrane. Type 2 cells are known as septal cells, and they secrete what's known as pulmonary surfactant. This actually will coat the inside of the alveolus and opposes collapse during expiration. Within the alveoli, you'll also find alveolar macrophages. These are called dust cells, and they are leukocytes that will engulf microorganisms. They may be either fixed within the alveolar wall or free to migrate. Now here we can see a couple of features of the alveoli and the respiratory membrane. So here we can actually get an idea of the pulmonary capillaries as there are red blood cells. We can also see the different types of cells. We see the type 1 cell, which makes up the majority of the alveolus, and then the type 2 cells, which are septal cells. And remember, those are the cells that are actually releasing surfactant. Here is an important image that kind of talks about the role of surfactant. And here, remember, alveoli are microscopic. The walls are very close to each other. And notice here, are they aligned by a thin layer of fluid, which is primarily water. Remember, water is a polar molecule, so water molecules are attracted to other water molecules. So you have to have something that's going to overcome the attractive force or the surface tension, and that is where surfactant comes in. Here we can basically see the role of surfactant, and notice the difference in the inflation level of the alveoli, entirely due to surfactant. Here we're also looking at the importance of having a very thin respiratory membrane. And so we can see here, that this is going to maximize the movement of our respiratory gases. So the movement of oxygen out of the alveolus into the blood, and carbon dioxide will be moving out of the blood and into the alveolus. Now, there is a condition that very much associated with the lungs, and that condition is known as pneumonia. This is an infection, and what happens during pneumonia is the alveoli actually fill with fluid, exudate, or pus. Pneumonia can be caused typically by bacterial or viral infection. Symptoms most commonly associated with pneumonia include cough, fever, difficulty breathing, weakness, chills, increased heart rate, and chest pain while inhaling. Now, there is a type of pneumonia that has milder symptoms, and that is known as walking pneumonia. When we look at individuals that are greater risk for developing pneumonia, those are going to be older or immunocompromised individuals, and also the illness tends to last for a longer period of time in these populations. We are now moving on to the lung itself as an organ. And when we look at the lungs, we find them in the thoracic cavity, and they are on either side of the mediastinum. Remember, that is the cavity where the heart is found. Within the lungs, we're going to find the bronchial tree and all the respiratory portions of the respiratory system. So the majority of the respiratory zone is found within the lungs themselves. Each lung has been described as a conical shape. There's a wide concave base atop the diaphragm, and then there's an apex which just points superiorly, and that can be found just behind the clavicle. Now here we can see the positioning of the lungs. So notice we have on the right lung, we have 3 lobes, where on the left lung, we only have 2 lobes. This gives us a much broader idea, okay, as far as the lung, but also take note of the positioning of the diaphragm. The diaphragm is skeletal muscle, and we'll talk a little bit later how it plays a very important role with respect to ventilation. Here we're looking at other views of the lung. So we have lateral views, and we also have a medial view, and we can see the differences between the right lung and the left lung, primarily the difference in lobes. And also, if we look at the posterior side, we can actually see a very important structure that we'll refer to anatomically as a region, and that is known as the hilum. And here, notice what we have. We have blood vessels and various parts of the airway and conducting zone coming into and out of the lungs at this point. Now, one characteristic of the lung that is really interesting is multiple bronchopulmonary segments. Generally, there are 10 segments that are found in the right lung and anywhere from 8 to 10 in the left lung. Keep in mind that these are autonomous units encapsulated with connective tissue. Each one of these bronchopulmonary segments is independent of the others. Each is supplied with its own segmental bronchus. We're going to notice that it's supplied with its own pulmonary artery and vein and lymph vessels. So in types of disease, you can have a bronchopulmonary segment removed individually instead of an entire lobe of the lung. So this is something we see that's available now because of laparoscopic surgery. The segments actually will be organized into lobules. Each of these lobules will be supplied by a terminal bronchial, arterial, venular, and a lymph vessel. Now, if we look at smoking and lung cancer, and we know smoking is a significant risk factor for many diseases, and especially when we talk about lung cancer. And if we look at smoking, it causes many respiratory changes with increased chance of respiratory infections. There could be cellular or genetic changes to the lungs themselves. Emphysema, it's well documented that smoking is a primary cause of this. We also know that smoking is a primary reason or cause of cancer of the lungs, but also of the esophagus, stomach, and pancreas. Stomach ulcers, atherosclerosis. We look at a lower birth weight in babies and pregnant women that smoke. Also, there's going to be a decrease in the delivery of oxygen and nutrients to all systemic tissues. Also, we know that smoking can contribute to bronchitis, asthma, ear infections, and these also can be due to secondhand smoke and not from smoking individually themselves. Now, lung cancer is a highly aggressive and frequently fatal malignancy originating in the respiratory epithelium. Smoking is responsible for 85% of all lung cancer. And if we look at symptoms that are associated with lung cancer, they include a chronic cough, the coughing up of blood, excess pulmonary mucus, and also increased pulmonary issues. Now, when we look at circulation and innervation of the lungs, a couple things to keep in mind. When we look at the blood supply, there are 2 different types of circulation within the lungs. We have the pulmonary circulation and we have the bronchial circulation. The pulmonary circulation replenishes oxygen and eliminates CO2. Pulmonary arteries carry deoxygenated blood to pulmonary capillaries. Blood is reoxygenated. Blood enters pulmonary venules and veins and makes its way back to the left atrium of the heart. The bronchial circulation is responsible for transporting oxygenated blood to tissues of the lungs themselves. If we look at the bronchial arteries, there are 3 or 4 that are actually branching off of the descending aorta, and there are also bronchial veins. These are collecting venous blood, which drain into the pulmonary veins. Now here we can basically see the 2 circulatory systems of the lung itself. So we see the pulmonary circuit, which was addressed previously when we talked about the systemic versus pulmonary circuit. And now we're looking at the bronchial system, and that once again is responsible for blood supply to the bronchioles and such. Now, lymph drainage is going to be important. The lymph vessels and nodes are located within the lung's connective tissue, around the bronchi, and in the pleura. They play a very important role in removing excess fluid from the lungs. Lymph is filtered through the lymph nodes, and particles are collected in pollutants that are not removed by cilia. Now, when we look at the innervation of the respiratory system, the autonomic nervous system innervates smooth muscles and glands of respiratory structures. If we look at sympathetic input, that's generally responsible for bronchodilation. Parasympathetic innervation is coming from the vagus nerve and will result in bronchoconstriction. There also are going to be signals sent from the larynx to the larynx from the vagus nerve. Now, the last structure that we have to address is the pleura. And this is a serous membrane that's lining the lung surface and the thoracic wall. It is made up of simple squamous epithelial and areolar connective tissue. It's subdivided into two parts. You have the visceral pleura. This is the part that is adhering to the surface of the lung. There's also the parietal pleura. This actually lines the internal thoracic wall, the lateral surface of the mediastinum, and the superior surface of the diaphragm. It is important to keep in mind that each lung is enclosed in a separate visceral pleural membrane, and this plays a role in limiting the spread of infections as they are independent of each other. Now, the pleural cavity, this is actually a space that's located between the visceral and parietal serous membranes. When lungs are inflated, we actually will consider this to be a potential space. The visceral and parietal layers are almost touching. Now, there will be a serous fluid that's produced by the serous membranes, okay? And we look at covering the pleural cavity surface, and it lubricates, allowing the pleural surfaces to slide by easily. Each pleural cavity has approximately less than 50 mils of fluid, and this fluid is drained continuously by lymph. Pleurisy, this is actually a condition which actually is inflammation of the pleural membranes. Symptoms include severe chest pain with breathing, inflamed membranes with increased friction between the visceral and parietal pleura, and generally only one side is affected. There is also something known as pleural effusion, and this is when there's excess fluid in the pleural cavity. This can cause shortness of breath and chest pain, and causes could be systemic factors, which are failure of the left side of the heart, pulmonary embolism, or cirrhosis of the liver. Others could be lung infections or lung cancer itself. Now, what's going to be important here, and we'll come back to this in the next series of screencasts on respiratory physiology, is intrapleural pressure. This is the pressure that we find between the membranes, and it is low. The chest wall is configured to expand outward. Lungs cling to the chest wall due to serous fluid's surface tension. There's an elastic tissue of lungs pulling inward. Because intrapulmonary pressure in the alveoli is greater than intrapulmonary pressure, the lungs will remain inflated. Lungs experience this outward pull from the chest wall. Now, if we look at the structures here, we can actually see primarily the pleural cavity, intrapleural pressure, and then we have the parietal pleura and the visceral pleura, and we can see basically the condition here. I do want to kind of come back here because it's important when we talk about this, because intrapulmonary pressure is going to be greater than intrapleural pressure. There's a typo there, I just caught that. Lungs will remain inflated. And so lungs will experience this outward pull from the chest wall. Now, going back to this slide, it really is important to make sure that intrapulmonary pressure is greater than intrapleural pressure, or intrapleural pressure is less than intrapulmonary. Kind of imagine what would happen if this pressure was greater than the pressure within the lungs. This would result in a collapse of the lungs, and it is important that that does not happen. Now, there are two conditions that are tied into the pleura, and they are known as pneumothorax and atelectasis. Atelectasis is actually collapsed lung. This occurs if intrapleural and intrapulmonary pressures equalize due to air in the pleural cavity. These lungs will remain collapsed until air is removed from the pleural space. If we look at pneumothorax, this is air in the pleural cavity. Air, for some reason, has been introduced externally. Kind of imagine a penetrating wound to the chest. Stabbing, gunshot wound would be examples. Air is introduced internally. Okay, there could be a rib fracture that actually impacts the lungs. It may cause intrapleural and intrapulmonary pressures to equalize. Small pneumothoraxes will resolve spontaneously, but a large pneumothorax is a medical emergency, and it will require the insertion of a tube into the pleural space to actually remove the air.